After development of resistance to targeted therapies, I think it's reasonable to try to understand the biology of the tumor that's developed and that's changed to see what's changed to lead to resistance. In terms of standard care outside of clinical trials, I think the most solid rationale for doing this is that about 5% of the time we identify small cell lung cancer at the time of acquired resistance to erlotinib. The presence of small cell is surprising to most doctors who treat non-small cell lung cancer, but it has been identified. And as such, I think it's helpful to find those patients, and then you can treat them with small cell lung cancer type regimens. And so I think that provides the solid rationale. In a big academic environment or an environment where a lot of clinical trials are available, most clinical trials are now requiring that the patients who go on to them have had a biopsy, and we know something from that biopsy about the biology of their disease. So for patients who have acquired resistance to erlotinib, that is, who've had a good response to erlotinib and then have growth, many trials say that only the patients with EGFR T790M, the secondary mutation often identified in EGFR mutant lung cancer, they have to have that mutation to go on this trial. Other trials say that patients have to have MET amplification, something else we see in patients with acquired resistance to erlotinib. So this sort of information helps the doctor pick a trial that's relevant for the patient and that they're eligible for. And as such, I think it should be standard in those situations.